next part. So now we are here in the bones of the lower limb, starting with the coxal bones, which we typically know commonly as the hip bones. But from now on, for us, it's going to be coxal, C-O-X-A-L. So these coxal bones forms the pelvic girdle, which is an area of the body that connects the appendicular skeleton to the axial skeleton. This coxal bone is 3 bones fused into one. The most anterior and inferior bone will be the pubic bone. The most posterior and inferior will be the ischium, and then the most superior and lateral will be the iliac bone, and it's the broader bone that we have. Is the one that you can touch if you just stand like this, kind of in your powerful pose. Okay, so that's the ilium. So it is fan-shaped, the ilium, and then this ischium supports the body weight when you're sitting. Now that you're sitting in the body of the ischium, in the ischial tuberosity, to be more specific. And then the 2 pubic bones, the one on the right and the left, meet medially and inferiorly to close the pelvic area into what we call the pubic symphysis. In this symphysis, we have a pad of fibrocartilage that connects the right and the left pubic bones. Now, the 3 of them, ilium, ischium, and pubic bone, or pubis, meet at the acetabulum. The acetabulum is a lateral part of the coxal bone where you have a cavity. Acetabulum means cup in Latin. So in this cavity, which is deeper than the glenoid cavity that we have in the scapula, it fits the head of the femur. So that the head of the femur rotates over this acetabulum, helping within our limits because, of course, we have more muscles in this area in comparison to the shoulder. We can do like 360-degree rotation, which is called circumduction. But of course, with the shoulder, we can do 360, but more freely. But this is just, remember, the complementarity of the shapes of the bones. So one has to be convex, the head, while the other one, the foramen, in this case it's called acetabulum, has to be convex. So you can have rotation. And then in this acetabulum, the head of the femur, which has the fovea capitis, it has at a point of attachment for a ligament that is called the round ligament that runs from the fovea capitis to the central part of the acetabulum. If you have eaten chicken thighs and they still have part of the coxal bone of the chicken, when you pull part of the thigh bone, which is the femur in the chicken as well, just as us, sometimes you have a little trouble to take it out. And then when you take it out, you see a little indentation in the middle of the head of the femur, and then you see a little ligament, that's the round ligament, and that's the fovea capitis. So functions of the pelvic girdle will be to transfer the body weight to the lower limbs, in this case to the femur first, and then protecting the pelvic organs. In females, will include the uterus, fallopian tubes, the ovaries. Plus, of course, in both genders will be the urinary bladder and the lower part of the intestines, which includes sigmoid colon, anus, rectum, etc. And then for this area, we have a lot of roughness surfaces that helps for insertion of muscles of the pelvic area, which help for us to maintain, for instance, standing position like the gluteal muscles, and also for laterally and medially rotating the thigh. So we have several areas there in these bones, and they attach the muscles in these areas, in the pelvic bone or the coxal bone. And then there are differences between male and female pelvic bones in shape, size, and physiological structures that allow the physiological function of the male and the female pelvis. So the female pelvis basically is adapted for childbirth. So here are the markings of the coxal bone. So for the ilium, we have a crest that runs superiorly in the ilium bone and runs from the superior iliac spine to the posterior iliac spine. It is more or less a little bit broad. And then the beginning of this crest starts at the most pointed anterior projection that we have, which is the anterior superior iliac spine. It's easily identified. So this, just similarly as what I told you before for many features of the coxal bone, it is a part where you have muscles attaching and also ligaments. ASIS, anterior superior iliac spine, it's a prominent projection anterior to the iliac crest. And then AIIS, anterior inferior iliac spine, it is found just below the anterior superior iliac spine. That one is almost impossible to touch. And this is an area for muscle attachment. Posterior superior iliac spine, PSIS, is the posterior end of the iliac crest. It's also hard to distinguish. With many luck, sometimes you can find it, especially if you don't have as many fat tissue or muscles in here in this area. Now, for posterior inferior iliac spine, PIIS, it is found below the posterior superior iliac spine. And then below this one, let me, instead of jumping, so medially to this iliac crest, we have a roughness surface. It's part of the iliac bone, which is the part where actually the sacrum connects to the iliac bone, forming the sacroiliac joint, or SIJ. So it's where the axial skeleton meets the appendicular skeleton. So this is the auricular surface. So the auricular surface from the iliac bone articulates with the auricular surface of the sacrum. Both of them have auricular surfaces. And then below the posterior inferior iliac spine, we have a broad notch that is called the greater sciatic notch. The longest spinal nerve that exits through the spinal cord runs in there to provide function to many of the muscles of the thigh. That's the greater sciatic nerve. And there is a tiny spine just below this greater sciatic notch, which is called the ischial spine. And then below this ischial spine, we have the lesser sciatic notch. So the ischial spine, it is located superior and posterior in the coxal bone, and points medially. If it's a male pelvis, points more medially than in females. And then we have the interischial line that runs between the right and the left ischial spines, that together with the line that runs from the sacral promontory to the pubic symphysis can be used to see if the head of a baby can fit through this pelvic outlet. So the ischial tuberosity is the large rough-net area from the ischium. It's found inferior to the body of the ischium, and that's where we sit. And then the lesser sciatic notch I already described to you, it's just below the ischial spine, while the greater sciatic notch is above the ischial spine and is larger in size. Now for the pubis. So the area in the mid part of the pubic bone anteriorly, which is where you have this fibrocartilage, it is the pubic symphysis. And below this pubic symphysis, there is an arch that it is used to measure the distance between the right and the left symphysis. This is called the pubic angle. If the pubic angle is less than 90 degrees, it's acute angle, it will tell you when you have both of these coxal bones together, it will tell you that it's a male pelvis. If the pubic angle is broader than 90 degrees, which is an obtuse angle, that points to you that it's a female pelvis. So it's greater the distance between the right and the left pubic bones in females than in males. And then the pubic crest is in the superior part of the pubic symphysis to the sides. It's called the pubic crest. It's a ridge. And then on the tip of this crest, almost to the side of the pubic symphysis, you have a little pointed projection that it is called the pubic tubercle. And now, the obturator foramen, it is a large foramen that it is found between the pubic bone and the ischium. It allows the passage of nerves and blood vessels. Now the acetabulum, I told you, it's a deep cup-shaped cavity between the three bones, the ilium, ischium, and pubis, and then articulates with the head of the femur to form the coxofemoral joint. So this is the different views of the coxal bones. So this is the middle view of the right coxal bone. This is the lateral view of the right coxal bone. So all of this broad portion of this bone is the ilium. This anterior inferior part is the pubis, and this inferior posterior part or posterior inferior part is the ischium. The three of them meet and they form this acetabulum. Well, just these two, sorry. These two meet, the pubis and the ischium, to form this acetabulum. And then what you can see medially? Well, in the iliac bone, you can see the crest, the auricular surface, which is this, and then you can see the anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, posterior inferior iliac spine, and between these two will be, of course, the crest. And there is this shallow fossa that it is anterior to this line that is called the arcuate line. This is the iliac fossa. And then below to this posterior inferior iliac spine, we have the greater sciatic notch. Then this is part of the ischium. This is the ischial spine. So the greater sciatic notch is above the spine. And then below the spine, we have another notch that it is called the lesser sciatic notch. And then this is the superior ramus of the ischium. This is the inferior ramus of the ischium. This is the body. So the body, you can see it medially, and then posteriorly to the body, you can see this roughness surface. This is the ischial tuberosity. This is where you are actually sitting right now. And then for the pubic bone, we have a superior ramus, inferior ramus, and this is the body. And then here is the pubic crest. And then in this little part, it's not labeled, we have the pubic tubercle. And this is the facet where you have the pad of cartilage, fibrocartilage. So when you have both the right and the left pubic bones together, they form the pubic symphysis. What you can see here posteriorly, laterally, you still can see the iliac crest, anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, posterior inferior iliac spine. Below this posterior inferior iliac spine and above the ischial spine, we have the greater sciatic notch. And then this part of the ilium, it is called the ala. And in the ala, there are several lines, including the anterior gluteal line and posterior gluteal line, and the inferior gluteal line, where the gluteal muscles, the ones that help us to stand erect, they insert into this part. And then in this fossa, the iliacus muscle, which is part of a broad muscle that is called the iliopsoas, inserts into here. And now here in this kind of inferior central part of the coxal bone, you can see the acetabulum. In the acetabulum, you have the fusion of iliac, which is all this bone, or ilium, pubis bone, which is this, the anterior bone and inferior bone, and the ischium, which is the posterior inferior bone. And again, between the pubic bone and the ischium, you form this foramen, which is called the obturator foramen. Then here the ischial spine, greater sciatic notch. Below this ischial spine, you have lesser sciatic notch. And then this is the ischial tuberosity, part of the ischium body, which is this. This is the superior ramus of the ischium. This is the inferior ramus of the ischium that meets the inferior pubic ramus. And then here the superior ramus of the pubic bone. This is the body. Here you have the crest, and in here you have the pubic tubercle. Several features of this coxal bone. Now, differences between the male and the female pelvis. So, this is female pelvis column, male pelvis column. This is the anterior view, this is the inferior view. So, this part, which goes from the iliac crest to the of one side to the other, it is called the greater pelvis. So it's wider in females than in males. In males, the greater pelvis is narrow. The space basically between the two anterior ischial spines. Not ischial spine, sorry. Anterior superior iliac spines. And then sacrum. This bone in females is wider and shorter. In males, it's longer and narrower. Acetabula is farther apart in females, in males is closer together. You can even see differences in the iliac. The iliac, it is longer and narrower in males than in females. Now, this oval space here, which is the pelvic inlet, it is oval shaped in females, and in males is heart shaped. And then for the pubic angle, the space between the right and the left pubic bones. So it's just below this pubic symphysis. In females, it's between 90 to 100 degrees obtuse angle, so it's wider in females than in males. In males, it is obtuse between 60 to 70 degrees. So that's for the anterior view. For the inferior view, if you see the distance between the two ischial tuberosities, in females is wider and in males is narrower. Now, the pelvic outlet, which is this, in females is wide, in males is narrow. The sacrum is wider, as you saw before here, and in males is narrower. And the coccyx, it is not shown in here, but in males is pointing anteriorly, while in females points posteriorly. And this coccyx is movable during childbirth, and also the pubic symphysis. It opens up a little bit more to allow the passage of the head of the baby. Any questions? Another thing that is not shown in there is like the male pelvis is denser. It has stronger markings, stronger bones than the females, and it's heavier than the female pelvis. So now let's move into bones of the lower limb and why they're important. So the bones are the femur, the tibia, and the fibula. The femur is the thigh bone, while the tibia is the middle bone of our leg, and the fibula is the lateral bone of our leg. Why they're important? Well, because they help us to support the weight of our body and also help us to move and maintain stability while we are standing. The femur is a single bone. It fits into the acetabulum of the coxal bone. It's the longest bone in our body. It's very strong. And then this one articulates anteriorly and inferiorly, or proximally, not inferiorly, proximally with the patella. The patella is the only sesamoid bone that we count towards the count of bones that we have, and it is triangular shaped with the base pointing inferiorly, proximally, while the apex points distally, and this one protects the knee joint. It is found within the quadriceps tendon. What is the quadriceps? It is this broad muscle that we have here anteriorly that help us to extend our knee. So when someone wants to work out their quadriceps, they have to do this movement. Flexion, extension. So it's a great extensor of our knee. And then the tibia and the fibula are the leg bones. The tibia, it is stronger, is found medially, and it is what makes the shin in our leg. The fibula is a little bit thin, it's found laterally, and only the tibia and the femur forms the knee joint. The fibula acts more like a stabilizer, but it's not part of the knee joint. Now, in the ankle, we have 7 tarsal bones, and the foot arch is formed by 5 metatarsals, and we have, just as in the fingers, in our toes, we have 14 phalanges. We have proximal and distal in the great toe, and in the rest, we have proximal, middle, and distal phalanges. And now for the metatarsals, just as for the metacarpals, we have a base, we have a shaft, and we have a head. The head, it is distal, it articulates with the row of phalanges that is next to it, which is the proximal phalanges. And then in our foot, we have 3 arches. We have the medial arch that runs along the long axis medially in our foot. And then we have the lateral, which is on one side, that runs also like this, from anterior to posterior. And then we have the transverse that runs between the medial and the lateral or longitudinal arches. And then in this area, we have the connection between the pelvic girdle and the lower limb in the proximal part of our bones from our axial skeleton. So why do you want to know this, Bill? Because it is vital to study posture, walking and running, and overall body support. So here are the features of the femur and the patella. So you're looking at the thigh. So this is the right femur, anterior view, right femur, posterior view. This is the diaphysis of the femur. This is the proximal epiphysis. This is the distal epiphysis. What you can see in this proximal part, you can see the head and the fovea capitis, which is a tiny indentation in the head of the femur. Just distally, you have the neck, and you have only one neck. It's not like the humerus, where you have 2 necks. Do you remember the names of the neck of the humerus? The one that is just close by the head? It's just barely by this area. What class is this? The first anatomy. And I'm trying to give you a clue. Huh? This is what? Anatomy, right? So remember, in the humerus, the neck that is just by the head is the anatomical neck. And below the neck, next to the shaft, we have is not physiological neck. If someone fractures their humerus, they have to have a surgery, typically, if it's displaced. So that will be the surgical neck. In this case, we don't have surgical neck. We have only one neck, which is this. This is the neck of the femur, just below the head. And then we have 2 rough-net projections that are called the trochanters. Just like as we have tubercles in the humerus, we have trochanters in the humerus. It's the equivalent, but they have a different name in the femur, sorry. So this is the greater trochanter, and this is the lesser trochanter. And only anteriorly, we have the intertrochanteric line, while posteriorly we have the intertrochanteric crest. The crest is more prominent, it's a ridge, but it's more prominent posteriorly, so that's why it's called a crest, while here we have a ridge, but it's more subtle. So this is the intertrochanteric line. So greater trochanter, lesser trochanter, lesser trochanter, intertrochanteric crest, intertrochanteric line, neck, head, fovea capitis, fovea capitis. Those are the proximal features. Medially, we have the shaft, nothing that you can see here anteriorly. Posteriorly, there is a line that runs from the inferior part of the greater trochanter to the medial condyle. This is the gluteal tuberosity that converts into the linea aspera. This means rough line. And then this linea aspera splits here in the lower portion of the shaft and goes into the lateral epicondyle. So this is the medial epicondyle, this is the lateral epicondyle, medial epicondyle, lateral epicondyle. Remember, a raised area above a condyle is called epicondyle. Epi means above. How do you know which one is medial, which one is lateral? You always have to look proximally. If the condyle is on the side of the head, has to be medial. Why? Because the head faces medially. And opposite, then to the medial epicondyle will be the lateral epicondyle. And in between these epicondyles, anteriorly and inferiorly, you see the surface for articulation with the patella, which is called the patellar surface. So here's the patella. In the anterior view, this is the base that faces proximally, and this is the apex that faces distally. It's like if it was a triangle. And it is convex anteriorly. Like if you feel your patella, it's not like this. You can feel like a little bump, so it's convex. It's the opposite of concave, which will be like this. And then posteriorly and distally, you can see these articular surfaces of the condyles, which are convexities. So this is the medial condyle and this is the lateral condyle. Again, how do you know? Well, you have to look to the head. The head always faces medially. So if it's on the side of the head, this has to be medial. And opposite is lateral. And you can see the greater trochanter here, which is lateral. Now, in between the medial and the lateral condyle, there is this fossa, which is called the intercondylar fossa. And then posteriorly, in the patella, you can see two facets divided by this line. So this is the facet for the medial condyle of the femur, facet for the lateral condyle of the femur, and then in the apex posteriorly, you can see the surface for the patellar ligament that you can feel just below your patella. Questions about the femur? Now for tibia and fibula, again, tibia is found medially in our leg, fibula is lateral. Fibula, it is thinner, the tibia is thicker. So you're looking at the right foot, the anterior view. So this is the tibia, the right tibia. This is the right fibula. So proximally here, and this is a posterior view, you can see proximally and anteriorly in the tibia this medial condyle, and then oppositely lateral condyle. In the superior surface, you can see the intercondylar eminence. So it's like two little peaks or projections that are between the condyles. Inter means between condyles. Intercondylar eminence. And then medially, a little bit distal to this intercondylar eminence, you have a rough net surface, which is the tibial tuberosity. The patellar ligament inserts into this tibial tuberosity, and it's the most anterior and prominent part of your tibia. And it's proximal. You can feel it. That's your tibial tuberosity. And then just below this tibial tuberosity, we have a fine lining here, which is called the anterior crest or the shin. This shin is not covered by anything else but the skin. Has everyone here heard their chin before when you're stomping towards an object? How does it feel? It's very painful because we have a lot of nerves there. It's not protected by anything, so it hurts a lot. So that's the anterior crest. And then distally, you can see a medial projection. This is the medial malleolus. That's the medial part of your ankle. Is that bony projection there? That's the medial malleolus. So how can you distinguish between this other projection, which is lateral, which is part of the fibula, and the medial? Well, you have to look above. So the one that is close to this actually is, to distinguish which one is the medial malleolus and the lateral malleolus is just by, medial condyle versus lateral condyle in the proximal region of the tibia. How do you know which one is lateral condyle versus medial? Well, you have to look distally. This medial malleolus is found only medially. So anything on the side of this medial malleolus has to be the medial condyle, and opposite has to be the lateral condyle.
What exactly happens when your knee is dislocated?
Your knee, when it dislocates?
Sorry?
Your
When
knee.
the knee gets dislocated, what exactly happens?
Well, have you suffered of that before?
Yes.
Okay. So these two bones do not align, full of misalignment. We will see in the next chapter, in the articulations chapter, where you have reinforcement between the tibia and the femur. You have ligaments that keep them aligned, and when these ligaments for some reason become elongated, or maybe they get torn apart, instead of having this alignment, one goes anteriorly or posteriorly over the other. So we have ligaments that stabilizes this joint. Now, laterally to the tibia, we have proximally the head of the fibula and what we call the proximal tibiofibular joint. And then the fibula has a neck below the head. It's not labeled in here. And then we have a shaft that is very long and slender in comparison with this, that is very strong. And distally, we have the lateral malleolus. And we have the connection between the tibia and the fibula distally, which is called the distal tibiofibular joint. And just below this part of the tibia, which is lateral to the medial malleolus, we have the articular surface for the talus. The talus, it is a bone that connects the foot to the leg to form the talofibular, tibial joint and the talofibular joint. So this part is a little bit concave, allowing the convexity of the talus to connect in there so that we can do this type of movement, moving your toes up and down like this, together with your foot, of course. Now here we have a syndesmosis, which basically is an interosseous membrane between the fibula and your tibia to basically keep this bone together and also to form compartments. We will see when we're studying the muscles how we have an anterior compartment, a posterior compartment. Not only here, but also in our forearm, and how you have functionality because of this compartment. So certain muscles are located in the anterior compartment that do something, and then in the posterior compartment we have others that do opposite of what the anterior compartment does. So again, you can see all these parts in the posterior view as well. So this is the intercondylar eminence. This is the lateral condyle, the articular surface of the lateral condyle here, the articular surface of the medial condyle here. How do I know this is medial versus lateral? You have to go below and see the medial malleolus. If you see here the medial malleolus, this has to be on this same side, the medial condyle, while the one across has to be the lateral condyle. And then the lateral condyle has a surface for articulation with the head of the fibula. And then here's the shaft of the fibula, this is the neck, this is the lateral malleolus. And this is the articular surface for the talus. Distal and proximal tibiofibular joints. Questions? So those are the leg joints. Leg bones. Now for the ankle and the foot bones. So we have these bones here that we call the tarsals. These will be the metatarsals, and of course these are the phalanges. Similar as for the phalanges and the metatarsals, you number them from medial to lateral 1 through 5. And you use Roman numerals, as you can see here. Now, so this is the talus, the superior view. This is the inferior view, or what they call the plantar view. And in the plantar view, you cannot see the talus. You can see the calcaneus, which is the heel bone. So the heel bone, if you see it here, covers this part of the talus. So you cannot see it through this side, but you can see it here. So this part connects to the tibia and the fibula. And it has this complementary shape that allow us to do this movement, moving the toes up and then moving the toes down. Now here we have the calcaneus, which has like a rough net surface for connection of a tendon that we call the calcaneal tendon or the Achilles tendon. We will see that later on. So here we have then the talocalcaneal articulation, and then the calcaneus anteriorly and medially connects to this almost rectangular shaped bone, which is called a navicular. Navicular for nave, which means ship boat in English. So this is the navicular. It is the medial of the tarsals that connects to these talus. And then proximally connecting to this navicular, we have three cuneiforms that run from medial to lateral, and they are called the medial cuneiform, intermediate cuneiform, and lateral cuneiform, also known as first, second, and third cuneiforms. That has almost like a quadrangular shape or cuboid shape. However, this large bone here that connects to the calcaneus and is lateral, it is called a cuboid because it's almost like a cube, square. So this cuboid connects to the fourth and fifth metatarsals. The lateral cuneiform connects to the third metatarsal, and then the second connects to this intermediate cuneiform, while the first metatarsal connects to the medial. And metatarsals, just as our metacarpals, they have a base that connects to the tarsals, and then they have a head that connects to the phalanges, and it has a shaft. And you can see them here in this view, the plantar view. So the shaft, the head, and the base. And here you have cuboid, the intermediate cuneiform, lateral cuneiform, and then here you have navicular, here's the cuboid, this is the medial cuneiform, and this is the calcaneus. And then typically at the head of this metatarsal, you have some sesamoid bones that sometimes are more than two, like in this case they're showing you two, and then they connect in this articulation that forms the great toe, which is also known as the hallux, which has only proximal and distal phalanges, proximal and distal, while the rest of the toes have proximal, middle, and distal phalanges. Now, what fits, or where do we land the weight of our body? Well, we landed in the calcaneus and the head of the metatarsals. And then here we have at least the view, the medial view. So we have a medial arch. Here we will have a lateral arch, and then one that runs between the medial and the lateral, which will be the transverse. So it will run like in this direction. So here we will have the medial arch, lateral arch, and then the transverse running like this. Transverse, medial, and lateral. Questions? So now we're going to review some clinical points from the entire chapter. So important foramina in the skull bones, optic canal from the sphenoid bone allows the passage of cranial nerve number 2, which is optic nerve, and also the ophthalmic artery. Important in vision disorders and optic nerve pathologies, these foramina. Superior orbital fissure is part of the sphenoid. It allows the passage of cranial nerves 3, 4, and 5, the first branch of 5, which is the ophthalmic branch of the trigeminal nerve. Cranial nerve number 4 is known as trochlear. This innervates or give function to only one muscle in our orbit, which is the trochlear nerve, the cranial nerve number 4. Oculomotor or cranial nerve number 3 innervates most of the muscles that help us to move our eyes. And then we have number 6 or abducens that also passes in this orbital fissure. So we have, as you can see there, 4 nerves that passes, 3, 4, 6, and 5, the ophthalmic. The lateral rectus, which help us to move the sides laterally, it is innervated by cranial nerve number 6. When someone has paralysis of this, either bilaterally or unilaterally, the person is going to tend to cross their eyes because they cannot pull the eyes sideways with these lateral rectuses. And then foramen rotundum, it is part of the sphenoid. This one, it is one of these foramina that allows the passage of the second branch of the trigeminal nerve, which is the maxillary branch. The maxillary branch basically gives innervation to our upper teeth and also to the gums within this area. It is important in facial sensory nerve disorders. Now, foramen ovale, which is also part of the sphenoid, it is very wide because it allows the passage of the third branch of the cranial nerve number 5. Cranial nerve number 5 has 3 branches, B1, B2, and B3. The widest is B3. This one goes through this inferior alveolar, it goes through this foramina that we have not only in the sphenoid, but we have the inferior alveolar nerve that is branch of B3, the mandibular nerve, that's the third branch of this trigeminal is called mandibular. So this one forms as well the inferior alveolar nerve. And this inferior alveolar nerve goes through the mandibular foramen inside the ramus of the mandible, and that is going to provide innervation or sensation to the inferior teeth and the gum within this area. So this sometimes get inflamed. It causes what is called the neuralgia of the trigeminal nerve. It's a very sharp pain, very intense in this area. Sometimes it is so intense that it is associated with whenever people get this pain with a feeling of committing suicide. Now the foramen spinosum, which is part of the sphenoid, transmit the middle meningeal artery and vein. This one, it is a site that it is important when someone has head trauma. Someone can have what is called the epidural hematoma. We will talk about the dura mater, which is part of this membrane that protects the brain when we talk about the nervous system. Now for the foramen magnum, which is part of the occipital bone, this, you saw it really clearly in the school, in the lab. This is so big that allows the passage of the spinal cord and also vertebral arteries. Remember, the vertebral arteries runs in the transverse foramina of the cervical vertebrae. That is part only of the cervical vertebrae. and also allows the passage of cranial nerve number 11, which is the accessory. This one innervates a broad muscle that we have here that is called the trapezoid. And then this is critical in trauma assessment for brainstem and spinal cord injuries. Now, jugular foramen, which is located between the temporal and the occipital bones, allows the passage of not only the jugular vein, the internal jugular vein, which drains the blood from the brain, but also the passage of 3 cranial nerves, 9, 10, and 11. Number 9 is called glossopharyngeal. Innervates several muscles in our throat, and also allows to taste molecules on our posterior third of our tongue. Vagus nerve is cranial nerve number 10, is the longest cranial nerve that we have. And then we have accessory or cranial nerve number 11, that not only innervates the trapezius muscle, but also the sternocleidomastoid, a couple of muscles that we have here laterally in the neck. So this one is important for cranial nerve function and venous drainage. Now the carotid canal, which is part of the temporal bone, it helps for the passage of the carotid artery. This carotid artery will be the internal carotid artery, which is branch of the common carotid that runs here on the sides of the trachea. Is going to provide blood supply to the middle part of our brain and the anterior part of our brain with its different branches. And also sympathetic nerve crosses through here. Internal acoustic meatus is part of the temporal bone, is found in the middle cranial fossa. It helps for the passage of facial nerve or cranial nerve number 7, which part of the motor function of this nerve is allowing to move our muscles of facial expression. Also allows the passage of a nerve that helps us to hear and maintain equilibrium, which is cranial nerve number 8 or vestibulocochlear. So this is important for hearing and balance disorders. Another foramen that we have is just below the orbit. It's part of the maxilla, is the infraorbital foramen. Allows the passage of infraorbital nerve and vessels. So it's important for facial anesthesia and trauma. Now, the mental foramen, which is found here, inferiorly and anteriorly, in the region that it is found on the side of this mandibular symphysis and the mental protuberance, it allows the passage of the mental nerve and vessels. So this, it is anesthetized for basically having some surgical procedures within the lower lip area and the incisors, the lower incisors, which is medial and lateral incisors, and also for facial surgeries. Any questions before we move into the preview for the next chapter? Okay, so preview for the next chapter, for articulation chapter. So we're going to see the types of joints that we have, the functions of these joints. We're going to see the classification in terms of structure and function. We're going to correlate the structure and function of these joints. And we are going to see as well the different structures within the joints, the different classifications of these joints. They have different structures. And we're going to see the type of movement that help us to perform. And then we're going to see joint disorders and injuries. So test your knowledge questions. Which bone is not part of the axial skeleton? I heard a lot of all the options, guys. Think and tell me. Where is the axial skeleton located?
Right down the middle.
So which one is not part of it? A. I think that option, I didn't hear it. Just, well, with few exceptions. But yeah, this is part of the appendicular. Question number 2, it's supposed to be number 2 here. Which cartilage type forms the intervertebral disc? Hyaline, fibrocartilage, or elastic? Fibrocartilage. Why? Because it's the strongest. We have to transfer weight in between the body of the vertebrae. So it makes sense to have the strongest, the fibrocartilage in between the vertebrae. True or false? The clavicle articulates with the scapula and the humerus. True. Paranasal sinuses help humidify inhaled air. True or false? Not all at once.
It's true.
True. True or false? The atlas is the first cervical vertebrae. True. I guess I forgot to tell you. So this name of Atlas comes from Greek mythology. Atlas was, I don't know if he was a god or not. I don't think so. But it was this guy who was very strong, who was kneeling in his knees like this, holding the world in his shoulders. So he was a very muscular guy. So since the head is our world, and the first cervical vertebrae carries this world that represents Atlas. Short answer, explain how the structure of the vertebral column and the pelvic girdle work together to support body weight and enable movement. Include key bone features in your answer. So what connects to what? First, what part of the vertebrae connects to the pelvic girdle bones? And we just saw it. The sacrum or sacrum connects to the coxal. At the SIJ, what it stands for? SIJ, what it stands for? Sacro what? Sacroiliac joint. So both auricular surfaces connect. Mm-hmm. So then the sacroiliac joint carries the weight and then send it into what part of the femur? So what part of the femur receives first the weight of our body? The head. And then from the head, the weight goes into the neck, and then into the shaft, and then into the lateral medial condyle, and from there goes into what bone? The weight. What bones do we have in the leg? The tibia and the fibula. So which one of the two carries the weight from the femur?
The bigger bone, the tibia.
The tibia. And then from the tibia, the weight goes into what bone of our heel? The calcaneus. And then the weight goes into the so if you have wet feet and you stand with your wet feet and you don't have fallen arches, you will mark with your wet feet the calcaneus, and then what else? The ball of your foot. But what do we have in the ball of our foot? The metacarpals. What part of the metacarpals? The head, the shaft, or the base? The head. So that's how we transmit the weight. And then what enables for us to do this type of movement? From the thigh bone and the coxal bone. What part of the coxal fits to what part of the femur?
So the head of the femur, right?
The head of the femur and the
Little space between them.
acetabulum. Acetabulum means cup. So next time you're drinking a cup, give me a margarita in an acetabulum. I will be looking like, you crazy?